product, and you'll still see that in some of the stuff that comes out of the government in terms of defining how they pay. But they pay on a per patient day basis. They're not paying on an episode of care, from the time they enter the system until the time they leave the system. They should be paid on the basis of progress, improvement, or at least preventing things. So, my background is cost accounting. And when I first walked into a large hospital in Springfield, Illinois, I started talking to them about cost accounting because President Nixon was saying you can't have a price increase unless you show a underlying cost increase. Well, they were wanting just to show total costs. Well, our total costs are going up because of the cost of health care and whatever. Well, no, what we were supposed to do is determine how they price their services and how they costed it. Well, they didn't. They couldn't. And so at that point, somebody came up with this idea that we would take 10,000 diagnoses, group them into 469 kind of like categories, and we would pay on the basis of input, not output. And it's still being done the same way. There is no accountability for an episode of care, from the physician to the hospital to the nursing home to the home care to getting people off of the system. They're still on the system, warehoused in nursing homes. And what my idea was, and I worked on developing software for 35, 40 years now with my son, is that we have a cost accounting system that you can track the cost of care from the physician office through the hospital, through the nursing home, into the home care, then home. And the whole goal is to get them better, get them home. And I was doing that in my nursing homes. We were utilizing our software to set up what was called care plans. And then within those care plans, we defined problems. The problems are the product. It isn't the diagnosis. A stroke is the person can't eat, walk, talk, think. Those things have to be fixed. And if they can't be fixed, then they have to be improved. And all of that entails labor, and entails supplies, and entails cost. And each episode varies depending upon how many problems the patient has. So we devised a system that would take 10,000 diagnoses down to 11 body systems. I mean, the body has 11 basic systems that runs the whole machine, so to speak, and simplify it down to the point where you're dealing with body systems. You're not dealing with 10,000, and it was increased to 16,000 diagnoses. Now it's 77,000 diagnoses. And they're still trying to pay on the basis of what they call a DRG, diagnosis-related group. That's hospitals. Then nursing homes are paid on a admission assessment, not on discharge outcome. So, my idea was never attractive to any of the providers because they didn't have to do that. They don't have to be accountable. And I think that's interesting when the bill's $3 trillion a year and we're not holding them accountable. And they're not going to like what I say because they're staying quiet because they don't want it to change. They don't want to have to be accountable like none of the rest of us if we don't have to be. So that's in healthcare. It's in the coverage and in the cost and in the quality because we don't have them defining what quality is for a stroke with respiratory and urinary and cardiac and complications, because statistics is that we have 40 million people that have 4 or more diagnoses. Chronic disease that we're talking about, and that's where the major cost is it costs closely to 80% of the healthcare costs is spent in the last 10 years of people's lives. And the baby boomers are just coming on, and they're not healthy. They've got problems. They don't exercise. They don't eat right. They're not internalizing the responsibility for paying the bill. But somebody else pays the bill. It's called externalizing the economics. And if you don't have to pay it, you don't worry about it. If you don't worry about it, you don't do anything about it. So you can say, Jerry, you're generalizing. I said, well, look at, go out on the sidewalk and take a look. We've got people that don't look healthy, don't live healthy. Mm-hmm. And there should be some responsibility for that. When we talk about what should I pay, should it be a privilege or should it be a right? Well, I don't think it's right when the young people are paying the costs for all the old people, because that's what it's coming to. And they're going to wake up and say, wait a minute, I can't even pay my college debt. And the deductibles on what's supposed to be Affordable Care Act, I can't even pay the deductible, therefore I can't get a doctor's appointment. I can't get admitted until I pay my deductible, so I have to borrow the money. They think their college debt's a lot of money. Wait till you start borrowing money for your health care deductibles. And that will only go up because there is no control of the costs. Zero, if you understand where I'm coming from.
Oh, yeah.
No cost definitely. Accounting, there's no accountability, and there's no definition of what outcome is. And do I have the solutions in my book? Yeah, I call it Shift the Paradigm, away from the government. Take it away. Privatize it. You got to get it out of their hands, because there's $600 billion that's being wasted in the system. And they claim it's because of fraud and abuse. Well, hell yes, they're going to blame the providers then. And that's what they're doing, is they blame the providers, come out and throw a few in jail and scares the hell out of everybody, and no one gets better. So, yeah, it's called SHIFT. It's Self-Help Investment Funding Trust, if you understand the acronym there. Each one of us would have our SHIFT account. It's withheld from our paycheck, and it goes into a mutual health insurance company that we own. Each person can choose one. It would be your typical health insurance companies that'll probably buy onto this because they wouldn't have any money. And it goes in there, and on the basis of your the expenditures, you're internalizing what your health care is costing. So then we will have competition. You'll ask what I'm paying for. Ask why didn't you get me well, and ask for a better physician or a better hospital. They're going to have to have a cost accounting system. So now you see what's behind all this is they need a cost accounting system. Do they need mine? I don't know. If I have one, somebody's going to copy it. I've got a prototype all built that I'm still trying to get into the cloud so I can sell it to when finally this whole thing crumbles and everybody's going to have one. I don't know. I'm probably a little crazy, but no. Until we have some way of accountability, costing their products. It's a product. It's not a stroke. It's not the problems. It's the outcome of, in care planning, you set goals for the problems and you track to see if they're improving or deteriorating so you can either discontinue it or accelerate it. And we had that going in our nursing homes. So we were discharging 57% of the people that came in back home. Because my philosophy is that's where they need to be. And everybody talks about, we'll pay physicians to make house calls, or we'll have medical homes, and they'll, it's harebrained. And I have a story that proves I'm right. Because in 1975, I went to Washington, D.C. as a representative of the American Healthcare Association of Nursing Homes. And I was supposed to be the expert on costs for nursing homes. Well, of course I wasn't, because no one had a cost accounting system. But I went to the meeting. I was a little late, and there was probably 25 professors around this table, and the assistant attorney general, who was a nurse, Faye Abdallah, was chairing it, and I kind of fell a little out of place. But when it finally came around the table, they were all proposing they should take the billings that they had received from hospitals and nursing homes, use a regression analysis computer program to determine cost, if you can imagine. And today, they're still trying to do the same thing. They're trying to use billings to back into costs rather than require costs to justify the billing. No wonder it's a mess. But anyway, I got up with my overhead and my charts and whatever, showing that, there's an element of fixed costs here, variable costs here. This is where the variable and fixed costs cross the profit line. And this happens on every episode of care. Oh, well, that's too complicated. That's too detailed. That's too administrative. It'll never fly. Okay, well, they hired me to come up with a white paper on how to implement it. And I submitted it. And what it was supposed to do, of course, was to create models of care based upon these 11 body systems, so we could forecast out using modeling, since computers were becoming able to do that, based upon the diagnosis of the problems, and have models that would show the interventions by the provider, and then the goals would be what they were trying to attain. So we could track the costs on a standard cost basis and forecast out what the break-even points were going to be, and hold the providers accountable for this process. And then when you go from a physician's office to a hospital, you have a care plan that's built on these models. And those models then are compared to actual by the cost accounting system at the end of a month or a period. And then the referral over to the nursing home, they have the same system. They're communicating through the same episode of care. And today we have no way of tracking any of this other than the diagnosis. And now they're penalizing nursing homes if they send the hospital back too soon, because they're penalizing the hospitals because they're taking them back and driving up the cost. It's never ending.
Yes.
So that's part of the solution. I'm going to kind of move on here to, that's only healthcare. I don't think we have time to talk about the tax system. It's my feeling that the current tax system is and growing our way out of this problem is never going to work. We can't grow our gross national product fast enough and long enough to pay these bills. And until we record them on the books, no one really knows how long it will take or what it would take. And I think it would realize that, hey, the people who made a lot of money off this great enterprise, American enterprise, are going to have to reinvest some of their money. Instead of taking it into a foundation and getting no taxes on the foundation, we got to start having a reinvestment back into our great consumerism that goes on here. But this all is packaged into my idea in 1991 was that we needed a third party. We have to have something that holds the two parties accountable. They may not win, and they may not be the majority, but within that structure we have what Europe has had for a long time, is we have the red and the blues don't collaborate into a monopsony and run everything. Is that happening? Of course it's happening. That's why we have gridlock. We can't get anything done. They're all debating issues, not solving problems. And at this rate, they're going to throw Trump out, and his acumen in business is not going to work there until we redo, privatize. My whole title on my book, American Enterprise Manifesto, is Downsize Government, Upsize Enterprise. Until we start privatizing most of these agencies that we don't even need, or they get in the way, this whole thing is crumbling into bankruptcy.